everyone can understand what what I'm saying. Uh, Not to waste time, let me begin. I have a 59-year-old female patient come up with a left breast mass, and then the ultrasound that might show that 25 by 23 by 22 millimeter mass in the upper inner quadrant. Uh, they classify it as virus 5, but unfortunately, she denied any further workup and came back after 15 months. In Vietnam, this situation not much, but there are some people who believe who don't believe in modern medicine. They believe something like herb or even meditation or nutrition, for example. They believe those things will kill cancer cell. That's why they reject any a modern medicine treatment. And after time, they realized those things didn't work. Then they came back to the hospital at more advanced stage. I'm sorry. And in the clinical examination, we found a left breast mass in the upper inner quadrant, 1.5 centimeter away from the nipple. It about 40 by 30 by 40 millimeter. That means it becomes larger than before, with irregular border, firm and fixed. A clinician also found a supraclavicular lymph node, approximately 15 by 10 millimeter, slightly irregular border, firm and mobile, without any skin change or nipple discharge. And the radiographic findings, the ultrasound also confirmed the mass and classifies at virus 5 plus a left axillary lymph node with the maximum size of 20 by 10 millimeter. Therefore, ultrasound guided fine needle aspiration was performed for the axillary and supraclavicular lymph nodes, and core needle biopsy was performed for the breast mass. Those images is the microscopic findings of lymph node, both the axillary and supraclavicular nodes. From there on low power, we can see that very high cellularity and a background of red blood cell and slightly granular necrotic debris. The tumor cell tend to stay together in a three-dimensional cluster sheet or net of tumor cell, something like a trabecular or a papillary light projection. And on high power, we can see the uh, cell pleomorphism there. It means that it varying in size and shape. There are some smaller one, and there must be a larger one there with side comparing to the next red blood cell there. The tumor cell have a funny looking shape, what I call that, the irregular shape of the nuclei, the coarse chromatin, and prominent nucleoli there. The cell tend to mold together or overlap. And sometimes the tumor cell exhibits a tubular formation is not really clearly there because we are dealing with a high-grade carcinoma. And in the background of scattered small lymphocyte and lymphograndular body, there the evidence of lymph node is lymphocyte and lymphograndular body. So we would diagnose it as metastatic adenocarcinoma. Uh, be, but because this is a metastatic disease on axillary and supraclavicular lymph node on the same side of the breast, so the patient state is at least 3C. This is the microscopic findings of breast mass. We have fine cores, and from low power, we can see that almost no normal breast tissue. We can see some lipocyte there, and the tumor net, uh, some small net, and trabecular, or they infiltrate the sclerotic stromal or desmoplastic stromal there. And from low power, we can only see some or even no tubule formation would be important for grading later. There are another core that so infiltrated the growth pattern the same. This is the intermediate power. We see the infiltrated pattern and a reaction stromal. On high power, we must assess the nuclear size and also the mitotic count. Uh, about the nuclear size, we can see there are some small one uh, as the same as the lymphocyte, but also there are many more large nuclei there uh, and differ in shape. Chromatin is vesicular and some have prominent nucleoli. Uh, about mitosis, there, maybe there, and they are a typical one, and there, and I have to count the total mitosis over 10 high power field. Uh, and then I choose the cutoff to score the mitotic count. Depends on the microscopic field diameter. The microscope that I use has the field diameter of 0.5 millimeter. So the cutoff for uh, score 3 is greater or equal to 15, but my count have 20 mitosis over 10 high power field that would merit the score 3. So overall, this is an invasive breast cancer of no special type, grade 3. And for the immunohistochemistry profile, first the ER, uh, I have we have to report the intensity of the nuclear staining and also the proportion of nuclear which stand for the marker. This we can see it diffusely and intensively stain. Just a little some cell that do not stand, and almost 100% the proportion of tumor cell that stand for ER. For PR, we also have to report the intensity and the proportion. Uh, these we can see that intensively uh, staining, and the proportion is about 60 to 70%. We also perform the HER2 marker for this case too, because it's the one important thing that related to patient treatment. From low power, we see that some area that show staining there and maybe scattered there, but not strongly stained, fairly faint staining. And from high power, we see that staining is not cover the whole cell membrane. It just covers some, it's not completely like a round circle. There you can see it just cover a part, not complete the cell membrane. So it would be HER2 2 plus. And if HER2 2 plus, the patient have to do the fish for to confirm whether the HER2 gene amplification or not. But unfortunately, my institution doesn't have a fish yet. Then the patient have to send her specimen into other lab, and the result take time. Other markers was performed in this patient is Ki67 and P53. The Ki67 from here we can see it definitely greater than 15% is related to poorer outcome. And the P53 that they are in my university, they are doing some research. Then they perform P53 on this on some invasive breast cancer. So my final diagnosis is invasive carcinoma of the breast. The biopsy specimen on the left upper inner quadrant. Histologic type is invasive ductal carcinoma of no spectral type, grade 3. Uh, Other factor like DCIS, lymphovascular invasion, perineural invasion, and calcification are not identified. These are immunohistochemistry profile. And other finding is important is metastasis to the left supraclavicular and axillary lymph nodes proven on FNA. After this case, I prepare some questions to for everyone to discuss. The first one I would mention is, do you see many bubble in the nuclei? I don't know whether it from the change in the nuclei come from a high-grade carcinoma or it's an artifact during the tissue procession, because I not only see in this case but also in other case in my institution, and I think that would be artifact maybe for the overheating during tissue procession. But I'm not sure that the reason why I posed the question for everyone to discuss. And another thing that I've heard that there is some correlation with the histologic type and grade and the immunohistochemistry profile. For example, in the low-grade breast cancer, usually it will express the ER and PR, and negative for HER2. And for high-grade carcinoma or basal-like carcinoma, they are usually triple negative. But in my case, I see that the histologic grade 3, but the ERs show diffusely and strongly stained. and I don't know is it usually or not. Other problem that I have counter it is the where to count my doses because the picture I show you there is the area have abundance of my doses, but the other area that lack of mitosis. And when I select 10 high power field, I just go around this area and then count mitosis. I don't know this practice correctly or not. And another term that I've heard that microinvasion is not in this case, but let's imagine if I diagnose as DCIS for some patient, but it shows some microinvasion that invasive carcinoma that less than 1 millimeter, if I correct. Uh, is it have any clinical impact for patient or uh, patient will be treated as invasive carcinoma or some consecutive plan like disease? So do I have to report the microinvasion or not? And there are mimickers or differential diagnosis. Those are my questions. And anyone who have questions or have some experience, and so please speak up and share your experience. Thank you.
Kamalji, do you want to lead the discussion?
Sure, yeah. First of all, I want to say it was an excellent presentation. So I think you started by saying that English is not your language and your third year, but I think this was perfect presentation for a biopsy case of invasive carcinoma. Pictures were great. So you have a very good camera and I can try some of these questions. So bubbles inside the nuclei, I agree with you. I think they are artifact. And I think other pathologists, so it's not related to breast only, but I think we see it in other tissue sections, other type of tissues also. So it's likely related to processing. IBC grade 3 usually positive for ER. I think you kind of answered your question. So as the grading correlates with the biomarkers. So as you go from grade 1 to grade 3, the ER positivity decreases and the chance of HER2 positivity increases. So by that, I mean most of the triple negative tumors, the triple negative, I mean ER, PR, HER2 negative tumors will be grade 3. There will be some that are grade 2, but they rarely would be grade 1. So all the high-grade tumors are either going to be triple negative or HER2 positive. ER positivity also, chances of ER positivity also decrease as you go from grade 1 to grade 3. So for this tumor, I agree with you, it's a grade 3 tumor for tubules 3, nuclei score 3, mitosis 3, but it's ER positive. That's not unusual. You can have ER positivity in grade 3 tumors. Most important would be the HER2. So if the HER2 fish comes back positive, then you will call it a triple positive tumor, which is fine. So one thing I will mention here is the epidemiology of the disease. It changes if you change where you are on this planet. So in US, you have 15 to 20% tumors are HER2 positive. 80% of tumors are ER positive, 20% will be ER negative, and 10% will be triple negative. So that's the epidemiology of breast tumors in the US. I was surprised when I go to India, the epidemiology changes. We have 30% triple negative tumors in India. Now in Vietnam, I think this is something, a homework for you if you want to do it. And if there's a data out there, see what's the epidemiology of breast cancer in Vietnam or Asia. See if it falls kind of in a similar spectrum, or I'm guessing it might be a little bit different. So your ER positivity, HER2 positivity may differ. Where to count mitosis? I'm wondering if any resident wants to chime in on that. Where do you count the mitosis in a breast biopsy or a breast excision? Does somebody want to answer that question from the residents? Or take a guess? Okay. So I think it's a great question, Lee. And so there is something called hotspots. So even in breast cancer, you find hotspots. And basically what I do is you scan the entire biopsy and you look for hotspots. And by hotspot, I mean you will find an area where you will see increased mitosis. And then you do it at a medium magnification. And once you have found that area of increased mitosis, you go to 40x and count your mitosis in 10 high power field. You will notice the same trend when you look at Ki67 IHC, that there will be an area where the Ki67 will be high, and then there will be an area of tumor where Ki67 is low. So you focus on hotspot for mitosis. Now, in an excision, if you have a larger excision like mastectomy, the general rule is you go to the periphery of the tumor, the edge of the tumor, which is more likely to be well fixed. There you will find better, more mitosis. But still, you have to go around, look for an area where you can easily appreciate mitotic figures on medium magnification, and then you go to high power and counter mitosis. So that's how you count mitosis. So microinvasive, you kind of answered your question. Microinvasive is defined as it's less than 1 millimeter, 1 millimeter or less size of invasion. And usually the setting is you will have a lot of DCIS and then very microscopic 1 millimeter or less focus of invasion. How do you manage it? That's a very great question. So it will depend on the clinical findings. How much DCIS do you have? ER status will also affect it. If the invasive tumor is ER negative, then the patient may get lymph node dissection also, some kind of lymph node dissection like sentinel lymph node. So the main question in that setting is, do you want to remove the sentinel lymph node or not? And most of the times, it will depend on multiple other variables, the size of disease, ER status, size of breast. Is the patient going to get mastectomy? Usually, if you're treating breast cancer with mastectomy, even DCIS, often you do a sentinel lymph node because once the breast is removed, you can't do the sentinel lymph node. However, the treatment of microinvasive disease will be a little bit more conservative or less treatment as compared to a fully large invasive breast cancer like this.
Hey, I wonder if any of our other mentors would like to comment on the HER2 issues relative to things like fixation time or scoring, and the whole concept maybe about HER2 low, which is beginning to be a factor when we are using HER2 not so much for trastuzumab, but maybe for antibody drug conjugates that have effectiveness in a variety of other settings. So I don't know, Esther or Mohan, any of you want to comment on those topics?
Sure. The breast specimen grossing, if we talked, I guess the grossing of any specimen we saw in the very first session, it's very important, the fixation time and cold ischemic time. And especially because the breast treatment is so dependent on the ER/PR HER2 status, it's very stringent and you have less than 1 hour of cold ischemic time and you have to have a certain amount of fixation time as well. And HER2 can be affected because of that. And when you don't have a good fixation, you maybe can't trust what you see. So scoring from 0 to all the way to 3, when you have intense complete staining of 3, that you can be confident it's positive and the patient will react or respond to the treatment. And the lower spectrum, we used to have, well, we still have 1 plus, which will be a low positive, and 2 plus with FISH negative will be still low positive. But now we are looking at something called ultra low, which is between 0 and 1 plus. And now we're getting more requests to go back to the metastatic foci and looking at the HER2 and rescoring whatever we called 0, whether if it has any staining at all. And it can be less than 10%, which is a cutoff for calling it 1 plus. So if you see any faint staining of HER2, the patient might be qualified for antibody conjugate drugs and called ultra low. So it's something that we're getting requests more to go back and reread our HER2s. And I'm sure it's going to be more popular as the time goes and there's more studies and it may be built into our templates of recording HER2s.
Yeah, there's this very interesting sort of bystander effect that happens when they use these antibody drug conjugates, that it not only kills the cells that have the receptor, but many of those surrounding are also adversely affected by the conjugated drug in those settings. And that's why even the traces of any potential receptor affinity target can still have a dramatic clinical effect.
Yeah.
So we have about 25 minutes. I think we'll go ahead and go into the breakout rooms. And I've divided you into 3 groups. Since we have an abundance of mentors here, I think you'll get some personal attention from them. And so I'm going to open the rooms. And then you can, I think each of the mentors has some cases to share and discuss. And when you're finished, we will allow you to just conclude from your breakout rooms at that point. So thanks, everyone. And please don't hesitate to contact me if you'd like to, or Kamaljit if you'd like to present a case in our next session. So Dana, you're in charge of this room. I'm just here to support you.
Oh boy. All right. Good morning, everybody. Let's see. I wanted to just, when I was a first year resident, and some of you are not, so some of you already know the drill, but I wanted to just make sure you know where we're getting our information from. And I think we've covered that a little bit. But just to kind of emphasize this, I pulled up some resources. Oh, now I got to sign back into the Blue Book, share my screen. So whenever you are starting out and you're learning what's what, it's really hard to know where to go, especially now that there's so much online. And there's so many different resources and it's kind of confusing, like what's up to date, what's not. Is this tumor still called a carcinoid or is it called a well-differentiated neuroendocrine tumor? So it can be a little confusing when you're first starting out. And pathology outlines, I think you guys probably all know most of those pages, especially the frequently used ones, I would say, like something like if you're looking up the Nottingham grading, or the Bloom-Richardson system, then it'll lead you to the right place. It'll give you the right information. But the gold standard authority is the WHO Blue Books, which I didn't even know about in my residency that they were online until the very end. But that's probably the best resource. Make sure you're in the latest edition, looking at the most accurate information. So you can go if your institution has a subscription, or if you buy an individual subscription, or you complete this training, and then you will get your subscription. But this is the best place to start. If you're like, I don't know even where to start, you literally just click on this breast tumors. You start with the introduction, read it one by one, and you will start to wrap your mind around what are breast tumors? How do I even approach breast tumors? And this is extremely helpful. If you wanted a short version, if you guys are aware of Kurt's notes, this is Dr. Kurt Schaberg from the University of UC Davis in Sacramento, California. He was trained at Stanford, and he updates these really frequently. These are really helpful, and he can give you not only diagnostic guidance here, but guidance on how to sign out. And even for descriptive things, I'll use his cytology templates quite a bit. So they're really, really helpful. He has some quizzes and things like that. So just kind of wanted to do a little segue that there is more than just pathology outlines available to you online. So I don't know about you, Dr. Hassel, but I was hoping to hear from the participants about where they're at with the modules, the breast modules, because last time we met, nobody in my group had completed any of the breast modules. So has anybody had a chance to dive into those?
I'm in the middle, so I'm in the middle. I haven't finished, but I'm learning for the for in the middle. The module is now is let me check my um uh, so, um uh yeah, I'm still in the middle for the fibrocystic and the proliferative changes.
That's fine. That's fine.
Yeah, great. Great to hear.
Dulam, how are you doing?
I'm halfway through my anatomic model.
Okay. Hua?
I'm halfway through my anatomic.
Okay, so still the first module, the boot camp module. Chanrina, how about you?
Right now I'm in the unit 2 of breast model.
Oh, great, great. So you're making progress, and that's really wonderful.
Yeah, that's great to know. It helps us kind of guide where we're going to go with the next session too. So don't be shy. We know you're busy. We know you're working. We know you don't have a lot of free time, so don't be shy about where you are in the course. So it's all, this is a very safe space to share and learn. So um do you think we should go through another case, Dr. Hassel, or what do you think?
Yeah, I think they'd love to hear you describe a slide or two.
All right, I can definitely pull one up. I have that email. 1 second. All right. So I think everybody's probably aware of Path Presenter and the Digital Pathology Association. These days, there's so much online, and these slides are all in your courses. But I think that when you first start learning, the best resources you're attending in your pathology residency, or if you're doing a medical school rotation, that's the best resource. And then, you go through your cases and you write down your notes with them, and you can go home. And then when you're looking at these cases, just take it slow. Starting out with what's normal and what catches your eye. The way that the presentation was done this morning was so perfect, with the follow-up questions of, what does this mean? Is this significant? Are these bubbles meaningful? Because sometimes bubbles are meaningful, like in papillary thyroid cancer. You kind of are looking for a bubble in the nucleus, and that's a very significant finding. So those are all like fantastic questions. Don't be shy with your questions as you go through these sessions, especially. We all had those same questions, so please keep that in mind. So anyway, we're looking at some breast tissue here. We're looking at a biopsy sample. As you know, breast is basically just a functional unit, and you've got ducts and lobules and fat. We covered that really well with Dr. Singh, so we won't spend too much time on that. I think you guys probably have an idea of what normal and what abnormal looks like. And I think right away, everybody's eye is probably being caught over here. I have another case pulled up. So a very similar idea. And that's how you kind of learn pathology, is you just keep seeing it over and over again. And finally, fortunately, it sticks. And then sometimes, like we mentioned before, you have to relearn what you've forgotten. And that's a natural part of the process. So here and here, this screen, let me see if I can turn this. Oh no, it doesn't allow me to rotate it, but you kind of see a similar
Lower
process.
right corner, you can rotate that 0 degree thing in the lower right.
Oh, I see it. Yeah. There we go. So just right away, you see that there's tumor cells, right? And this one looks a little different than that one, but you can tell right away, oh, there's cells here in this stroma that are not supposed to be here, right? So when you see that, you say, okay, I found the tumor, and what can I see in the background that will give me any kind of clues on what it is? And what does the tumor itself look like? So that's where I always start. On low power, I go in, I say, well, there's something over here in this depth of space that's way too cellular compared to the background, right? There's like nice pink and light, and there's some fat. There's no tumor over here, but we can tell right away at low power the architecture is abnormal. So when I go in and I see, okay, there's some cells. Now, how do we know what's what? So this is what I was talking about. You go to the WHO and you say, okay, so what are my different types of breast tumors? Here it is, all the different types laid out. And as you read that, you'll start seeing the photos that are in there, and you'll start picking up, oh, okay, this looks like more like this, and this looks like more like this. But in the breast, we know that ductal is extremely common. You are looking at a cancer, in epithelial cancer, you're mainly in those groups, ductal and lobular cancers. So this one I think is a little bit easier to appreciate that this is ductal, because you have little ducts formation. You have some cribriform DCIS in the background. Maybe that one's starting to cribriform a little bit. Those type of things can give you some clues of what type of cancer you're dealing with. I'm not thinking that it's a stromal cancer because I see a proliferation of ducts in front of me. And so just like the presentation this morning, then we would go through and we would say, okay, well, how bad is this tumor? And that's basically called grading. And so first off, I should say, the grossing of this tumor is very important. So we would want to measure the size at grossing to be extremely accurate. You get those rulers out and you want to get down to the nearest millimeter how big those tumors are when you're grossing. And you want to see, is there one tumor or are there multiple tumors? How far apart are those tumors? Those are all extremely important things when it comes to breast tumors. So when you don't have all that stuff memorized in the beginning, You just have that rule in the beginning at, okay, at grossing, I have to be down to the nearest millimeter, how big these tumors are, how far that is from each other, how far it is from the margins, those type of things, all extremely important. So then microscopically, we kind of do that same process again. We would measure the tumor. How big is this tumor? Even on biopsy, we do that. We note things like, is there perineural invasion? Like I said, we grade it and we decide what type of tumor it is. Without stains, we can be pretty sure that this is a ductal type of tumor. We have that hint in the background of the DCIS, and we have nice tubule formation. This one's a little trickier because they're starting to form small clusters and some single cells. And so here we would want to use E-cadherin, and if it's available, P120 maybe, to differentiate whether this is a lobular phenotype or a ductal phenotype. I've probably given you a lot of information. I don't want to deep dive too much because you're in the beginning of learning, and it's a little difficult to remember everything when you get into the details. But anybody have any questions? So I could stop right here and pause. And I'd also be interested to know, are you working in a setting where you have routine access to IHC, or especially the prognostic? Specifically ER, PR, and HER2?
Yeah, Dulam, what is it like in Mongolia? Do you have immunohistochemistry in your lab?
Sorry, can you repeat your
Yeah.
questions?
Do you have immunohistochemistry in your laboratory?
Yes, we have.
Yeah. Okay. And I believe I'm quite sure they do in Cambodia. Hua, where you're working, you have IHC, right?
Hello, hi, Professor.
Yeah.
In Cambodia, yes, we do have IHC, but only in one public hospital, big hospital at Calumet, and I
Yeah.
haven't been trained there yet. So
Okay.
sorry.
No, that's fine.
Yeah, that's really helpful to know. And don't be shy about the training. Even in the US, not every lab is doing it in-house. I don't know if you know that, but it's not uncommon to have things like ER, PR, and HER2 sent out or PDL1 sent out. So it's not that every lab in the US is doing every single stain. Actually, it's quite the opposite. So you're not alone in that. And it goes for our trainees too.
So one of the things that helps to distinguish a learning pathologist or learning trainee from an experienced pathologist is their whole approach to the slide and where they focus their attention. And I think Dana's approach to these two cases is quite illustrative of that distinction, that at low magnification, a pathologist trains their eye to see where the abnormalities are, and then can, after they've scanned the whole slide, put their higher magnification focus on those areas that they have identified at low magnification. Of course, you may at the beginning think that, oh, these blood vessels over here that look red and streaky, those may be abnormal. Or even something like a fold in the tissue or something can look like an abnormality. And that's just part of what you have to train yourself to learn. So at the beginning, you should see a lot at low magnification and then go down and verify at high magnification what's important and what's irrelevant. And over time, you will develop that ability to look at a biopsy like this image, and just by virtue of the nature of the degree of cellularity, the pattern of the staining and so forth, you'll be able to detect that it's abnormal, and also likely begin to predict that it's going to be a lobular differentiation type of tumor rather than a ductal cancer or something like that, by virtue of those subtle changes. But that skill or that ability is developed by low power study initially, and then a lot of going down to higher magnification to see and confirm what is causing that. And that's a very important skill to develop and to practice at the beginning. So going low magnification to high magnification and back and so forth is really very good way to train your eye to recognize the anomalies, the abnormalities at low magnification, so that ultimately you become much more proficient and more efficient at examining slides and picking out where the diagnostic information is really going to be found.
Yeah, I remember my attendings in my first and second year just saying, go back, and because I would go straight to high power, and they would say, go back to low power. You have to start on low power. And that's true. It's just all about training your brain.
What do you?
Any questions, guys? Or sorry, go ahead, Dr. Hassel.
Oh, I was going to ask you what you do to distinguish or to pick out the rare foci, say of a single duct that has atypical hyperplasia or a little DCIS in it. How do you avoid missing those sorts of things?
Oh God. Well, you should answer this question, but for me, I am only my third, fourth year out of training. So I did for the trainees, I did a subspecialty training in GI. And so last couple of years when I started looking at breast again, well, it would take me 4 hours to go through a lumpectomy specimen. So, and there's no shame in that. So like Dr. Hassel's saying, I didn't want to miss that tiny microinvasive focus. And I think the key is just going slow. When you're new at an organ or you're going back to an organ, you just go slow. You take the time. It's a little bit painful. But it's just something you have to slowly train your eye to pick up faster. And then the next time you see a case, you'll get a little bit faster. And the next time you see a case, you'll get a little bit faster. So that's been my experience, going from a subspecialty trained brain to general sign out.
Yeah, I think there's an element, you have to have an element of what we would call compulsivity, being very compulsive and disciplined to force yourself to examine all the tissue, to examine the whole slide, to examine all the slides as you're beginning. And as you do that, then ultimately you will learn what the questions are that you need to answer in subsequent slides or subsequent processes. So, for example, in a breast needle core biopsy like this, your laboratory may cut several levels. And as you examine the first level, say that was this level, you might say, oh, this looks like lobular carcinoma. And then you go down and you verify that, yes, indeed, that looks like an infiltrative single file pattern and so forth. And I don't see, much in the way of tubule formation, and they're not highly pleomorphic, so it's more like a regular lobular carcinoma. So you've established that part of the diagnosis. You don't need to establish that again and again on the subsequent levels, but there is additional information that you do need to be looking for. like perineural invasion, like accompanying ductal carcinoma in situ, or lobular carcinoma in situ, or some other finding that might add to or enhance the staging or the characterization of the process that would have implications. So, if I'm examining this as the first level, I'll say, okay, I've got the primary diagnosis, but the additional tissue that I'm going to examine is going to, add a little bit more information around the periphery that, it's, got some DCIS as well, or some atypical hyperplasia as well. And those are the kind of questions that I'm looking for or looking to answer as I look at the second and third level of a particular case. And that helps you to become more efficient in terms of your process and become speedier as you know what question it is you're trying to answer as you look at the subsequent slides.
Yeah, it's definitely a process we all go through, and you shouldn't feel any shame about, when you miss things and you have to go back through the whole case and look for that again because you forgot to look for lymphovascular space invasion, for instance, after you've already nailed the diagnosis and all of the other things in the CAP checklist protocol. And then you forgot to do that one thing and you have to go back through. Every single pathologist learned that same way.
Yeah. So we're almost out of time. Do any of you have questions you want to bring up?
Want to share a little.
I understood something about the nipple.
Can you hear me?
Yes, we can hear you.
I want to share a little.
Okay.
I am working in Vietnam National University, and I am studying at some hospital in Hanoi, such as Bạch Mai Hospital. IHG is very developed here, but I am studying hematoxylin elgin stain slide. Sometimes I look at IHG slide, but I find it so difficult to determine its percentage. For example, how much is positive for KI 67? Can you hear me?
Yes, yes. So how do you quantitate Ki67 staining?
Yes, I think it is so difficult to me to determine the percentage.
So I think the experience has been that some people will estimate based on kind of what they see, and that can be useful. You can certainly see when something is very high or when something is quite low. But because for some tumors the cutoff level is different, say for a neuroendocrine tumor versus a breast tumor, you may need to use a more fail-safe method. So sometimes that involves taking a picture of a high-power field, and then on the picture, printing the picture and actually crossing off each nucleus as you count it. Is it positive? Is it negative? And so forth. It's very tedious to do it that way, but having that discipline of doing that can help you to then sort of adjust your estimating percentage of what is a high percentage, what is 60%, what is 40%, what is 20%, et cetera, if you do a lot of them. But if you only do them now and then, you may need to continue to manually count them field by field. The caveat, though, of course, is that for Ki-67 staining percentages, where you have to give a quantitation, you should only count the percentages of tumor nuclei that are staining. So sometimes things like lymphocytes or stromal cells, endothelial cells, and so forth may also take on the marker, and you have to be careful to not overestimate the tumor, the percentage staining, because you've counted these other cells in your total count. Fortunately, coming down the road are image analysis tools that will reduce the need for a pathologist to manually do that. So in some settings, there are algorithms that can identify, if you draw the circle around the area of interest, they can identify positive and negative and very quickly give you a count. But until those tools are very widely available, we have to be disciplined and do the manual counting. What do you do in your institution, Dana?
I've always found that it's up to every individual pathologist to decide how they do it. I'm pretty diligent about it, and I've always had access to digital. So I outline a box digitally and I count it manually.
Okay.
Yes, I will try to gain more experience. Thank you so much.
Good question, Hua. Good question. Anyone else have questions? Well, if not, I think we can let you go. And I'm going to keep the video going because people are still talking in one of the other rooms. But we will see you again in a couple of weeks.
Thank you, everyone.
Thank you.
Thank you. Bye-bye.
The discussion. Okay, I guess we will wrap it up. Dr. Hassel, just.
Yeah, I just came in to see that you were still talking, and I didn't want to shut off the Zoom until you were done.
I think we just wrapped up. We are just done. I was just asking them to, share a case if they have, and because that just builds the momentum.
Yeah, great.
Yeah.
Well, good session today. Good presentation, V. Excellent job.
Thank
Thank
you.
you so much. Yeah.
Nope. Thank you.
Yeah.
All right, we'll see everybody in a couple of weeks.
Yep. All right.
Great.
Thank you.
Bye.
Bye-bye,
you.
guys. Yeah.